So good morning, welcome. I'm Sarah Witherson, she, her, white woman with gray and brown hair and glasses. I will put myself on screen. There we go. I'm lead staff for the Medicaid Advisory Committee, or the MAC. And this is the MAC's public meeting for February 2024 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. So I'm going to share a few logistical announcements before we get started. We'll ask folks to mute themselves when they're not speaking. If you're joining by phone, we'll ask you to please mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to go, it's better to hang up and rejoin the meeting. And MAC members, please use the raise hand button if you have a comment or question, or put a note in the chat. The Medicaid Advisory Committee has built in time for discussion after each presentation. MAC members will speak first. When we've exhausted the questions from the MAC members, if there is time remaining for the agenda item, we'll take general questions. We also have 10 minutes for public comment near the end of the meeting. We have ASL and Spanish language interpretation available for today's meeting. You can pin the ASL interpreter's video by clicking on the More button next to their name. There's also a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screen. So now I'm going to hand it off to MAC co-chair Heather Jeffress to take us through our meeting. Heather.
Oh, thank you, Sarah. Welcome committee members and members of the public. Before we get started, I wanted to invite our new member representing the Oregon Department of Human Services. And we have our liaisons.
Double check, sorry. Oh, I see Peter Starkey and Dr. German are on.
Oh, wonderful. And we're so excited to also announce our new OHPB, that is the Oregon Health Policy Board, excuse me, liaisons to introduce themselves and say a few words about why they have joined the MAC. And again, Hillary Thompson is from ODS.
Oh, ODHS.
ODHS, thank you. So sorry, Sarah. If Hillary, are you available?
Yes, hi, good morning. I am Hillary Thompson. My pronouns are she, her, hers. I am a white woman with curly reddish brown hair that I wear in a bun. I'm wearing dark rimmed glasses and a gray sweater, and my background is blurred. I apologize if you hear my dogs barking. I am a policy analyst with the Oregon Department of Human Services, Aging and People with Disabilities, Medicaid Financial Eligibility Policy Team. And I am very excited to be here. Thank you for having me.
Oh, thank you, Hillary. Welcome. And Dr. German, are you available? Introduce yourself.
Hi, it's Peter. I think Tony put in the chat that his Zoom isn't working very well and his audio and video isn't functioning.
Oh, thank you, Peter. Appreciate that heads up. Thank you. Why don't you go ahead and then yourself?
And I apologize to interrupt. If we can have Jordan, who is the host, to assign Rosie and I as interpreters, please.
Will do, Victor. Just one quick moment.
Thank you.
Thank you for our technical moment, everyone. All right, we're a team. We can do it. All right, Peter, if you could go ahead. Thank you so much.
Or Peter Starkey, I'm the executive director of Folk Time. I use he, him pronouns, and I am an individual who has lived experience with mental health. Recently joined the Oregon Health Policy Board. Oh goodness, it's only been a couple of weeks, but definitely interested in the Medicaid Advisory Committee and talking with the chair because I am a firm believer that Medicaid ensures accessibility to healthcare, equal access, and the availability of healthcare. And I'm a strong proponent of it. and being able to make sure that healthcare is accessible, especially to the most vulnerable of Oregonians and US citizens. So very interested in being able to support the work of this committee and being able to work with Tony, Dr. German to bring and be a bridge between this committee and the Oregon Health Policy Board.
Oh, thank you, Peter, so much. As one of the co-chairs of the Medicaid Advisory Committee, I'm just so pleased to have two amazing representatives from the Oregon Health Policy Board to join us in the work, and really appreciate that, and do apologize, Tony, that you don't have access to video, but welcome, and audio, and we're glad you're here. So with that.
Oh, it looks like Dr. German might be available by phone. Do you want to give that a try? See if you can introduce yourself. Okay. Dr. German, if you're speaking, we can't hear you. Audio not working on the phone. Thanks for letting us know. Sorry about the technical difficulties.
And it happens, doesn't it, Turn? Well, again, thank you, Dr. German. We're just so pleased to have both Peter and you here, and welcome also to Hillary. So I'm excited to start working with you. So with that, let's go ahead and start the formal roll call. Calling for Dr. Caroline Barrett.
Sorry, I was struggling with my mute. Yes, I am here. Good morning.
Good morning, Caroline. All right, Awab.
Good morning, I'm here.
Oh, good morning. DJ. DJ Rhodes. And for the record, we know Gabe Triplett is absent today.
DJ just entered.
Oh, DJ. DJ, are you here?
Probably just getting set up with audio.
Oh, okay, great. We captured that through chat. Okay, roll call recognized through chat. Myself, I am here. Hillary Thompson.
Good morning, I'm here.
Thank you. Jerry Weeks.
I'm here.
Wonderful. Kaya Adams. All right. Kelly DeVore.
Good morning, I'm here.
Is that Kelly?
Yes, I'm here.
Thank you, Kelly. Wonderful. Lisa Pearson.
Yeah, this is Lisa Pearson. I'm a consumer member from Benton County. I am mostly interested in promoting the voice of the consumers on OHP. Sorry guys, I'm having video issues. I'm not seeing any of you anymore, so I don't know if you're seeing me, but I don't see myself either. So I'm just going with audio.
Thank you, Lisa. Thanks for letting us know. And Ronnie St. John.
Good morning, I am here.
Great, welcome, Ronnie. Shannon Buck. Dr. German, and I think we'll just go ahead and mark him as here. Thank you. And Peter Starkey. Is Peter still with us? Okay, great. So
Yes, I
with
am.
that- Oh, thank you, Peter. Thank you very much. We have to do our little formal roll call after introductions. Thank you so much. All right, I do believe we have quorum. Is that accurate?
That's accurate.
Okay, thank you. All right, excellent. Welcome, committee members. Last week, you received the draft minutes from our January meeting to review. Let's all take just a quick moment to review those minutes or hear from you about any errors or omissions you may have seen in those minutes. Okay. I do not hear any concerns regarding the minutes or suggestions for revision. Okay, so with that, do I have a motion to approve the January meeting minutes? And please say your name so we can get notes when you make the motion. Thank you.
Gary.
Did you catch that?
Yeah, so I think we have a motion from Jerry Weeks to approve. Jerry, if that's right, I'll just let you know that your audio is a little muddy.
Wonderful. Thank you, Jerry. Do I have a second?
This is Ronnie St. John. I second the motion.
Any objections? Any abstentions? The motion carries. Thank you, everyone. All right, so our first presentation day, we'll just go ahead and get started. Thank you, everyone, for helping with the business. Is we will have a presentation on the public health emergency unwinding. It's an update from the cross-agency team working on making the transition from enhanced benefits that were available during the public health emergency as smooth as possible for Oregon. And I have to say, and for our Oregonians on the plan, I have to say from their previous updates, the Medicaid Advisory Committee members and myself have really been impressed with the excellent work and the continuous improvement that this team has been doing. So really look forward to the further update today. So I'm happy to welcome back David Valentine from OHA and Jillian Johnson from ODHS. Are you ready to start?
I sure am. What a great intro. Thank you so much.
Oh, absolutely. You guys have just been really doing some excellent work. And actually, we're getting some kudos nationwide because some other states are having a little more of a struggle. So thank you so much for all the work that you do, you and your team.
Sure, absolutely. I appreciate that. You know, I always try and lace a little bit of pragmatism and transparency about what we're anticipating as our biggest challenges, but we are having a lot of success with what we're doing. So I don't want to miss that celebration along the way. So thank you so much for having us. My name is David Valentine. I'm the PHEU lead for the Oregon Health Authority. I use he, him pronouns. And I'm partner Jillian. Do you want to give a quick intro to yourself too before we get started?
Yeah, absolutely. Jillian Johnson. Hi, team. My pronouns are she, hers. I'm a deputy director for the Oregon Eligibility Partnership, which is part of the Oregon Department of Human Services, and lead sponsor, et cetera, on the ODHS side regarding PHE unwinding. That being said, David is the real driving force in in pretty much all of this. And so he's going to be doing most of the talking today, and I will chime in as needed or et cetera. So, but happy to be here with you all.
Jillian. All right, let's go ahead and bump up a slide. Maybe one more. Here we go. So just our quick overview. This is a really nice high-level snapshot of where we're at right now. So progress renewing 1 in 3 people in Oregon. You can see 85% are complete. In process is 6%, and then 8% are planned upcoming. This is really going to be a driver for you can see that there's all the people in process are planned. We have a lot of folks that are still to come, that we also consider some of our folks that need perhaps some of our highest levels of personal assistance and help along the way. So this is going to really color kind of some of the next slides too as we walk through. So we go ahead and bump up one more. Okay, so we have talked in the past, we had 2 main populations that we needed to kind of readjust when we were going to ask them to renew for a couple of different reasons. The first one is that our federal partners, CMS, said that we needed to change how we were processing some of our members that we refer to as ex parte. You might have also heard them referred to as passive renewal members. So these are folks that we send a notice to and say, hey, you are going to be approved based on the information that we have. If this doesn't look right, let us know. There's some variations amongst all of that, but that's in general what that looks like. The other group is our OSIPM population. And I never can remember this acronym, but these are folks who have a lot of disabilities. They are Medicare and Medicaid members, and they are a very high risk population. So we had some feedback from some legal groups around the process for those members and specifically around resourcing for those members. So we have updated our system, or in process, I should say, of updating our system. Thank you, Hillary. I was hoping would back me up there. I appreciate that. So we have now sought and gained approval from CMS to adjust our timeline. And this timeline chart represents our new plan. So the orange and the yellow really represent the plan that's we've been driving to and using for the last year. The blue portions are the new the approved timeline that we are operating under to initiate the renewals for the members of those populations that I just kind of walked through. So those are going to start initiating in June, July, August, September of this year. And then the response period, that kind of expanded response opportunity that those folks have based on the public health emergency will continue for those members through February 25. So that is now the longest possible end date of PHEU redeterminations. The last bits in 2025 will probably be quite small as far as members that are still somewhere in the process, but that is now the full universe timeline of the public health emergency. I think last time we spoke, that was kind of in flux, and we were still in our proposal stage with CMS. But happy to say that that CMS has approved that, and CMS is the Center for Medicaid Services, part of our federal government partners there. So any questions about that piece before I move on?
No questions, but excellent work on that. I'm knowing just enough about data platforms to get myself in trouble. Excellent work identifying a vulnerable population and how to support them in continuing their Medicaid so that they don't have any disruption to their healthcare, or as least disruption as possible. Really, all of us on the committee appreciate that work. Thank you.
And we really thank you for that. And I'm very, my nerves settled greatly when our federal partners approved our proposed timeline. Really gives us firm footing now for the rest of the year. And then second, we are really using this too as an opportunity to say, okay, we have a time between now and June to really look at our processes, our outreach plans, our communication plans, and really say, do we have anything else that we can do to help those members specifically, because we have them now scheduled in such a distinct period of the PHEU process. So that's exciting. I think the next couple of months, I'll have more updates about what specifics we may have. We've done a couple of tabletop exercises to kind of work through those kinds of things, and we'll have more details on that in the coming months. So let's go ahead and jump to the next slide here. Oregon has the second highest renewal rate in the nation. Virginia's got us beat by just a hair. Who knows where we'll be at by the end of this? We might flip-flop places there, but things are going very well as far as our delineation between disenrollment and renewal. We've put a lot of things in place to keep people insured as much as possible. And then those folks that are disenrolled, I want to remind that we have a great marketplace team that's available for members who may be exiting. And so we have folks that are there to help guide them to their next phase. If it is no longer going to be a part of our programs, in somewhere in the marketplace with a subsidized plan or some other plan. So the next slide is Oregon ranks first in preventing unnecessary paperwork. And so you can see in comparison to some of the other states that are right below us, this is one that I kind of like to add a little bit of pragmatism to. I don't want to get too downer, but I'm very, very glad that we're preventing unnecessary paperwork for folks. We've done a lot of work to do that. Sometimes though, when we talk to members won't always maybe feel that way. There's still a lot of paperwork. We have so many different programs beyond medical, SNAP, TNF. There can be times when people are still receiving, I think they would consider a healthy amount of paperwork. Still, we're doing a great job at minimizing this in the medical side under the PHEU. And that's definitely something to be celebrating. A good step forward in keeping that paperwork and that noise reduction down for members as they navigate these very complex systems that we have available for them. If you want to see more stats like this, you can see a link there to the KFF analysis of state aligning dashboards. There's a ton of different kinds of comparison things that you can look at. We just pulled out a couple here. So let's go ahead and jump to the next slide. This is just an outcome summary of where we're at. Renewals completed so far, we're at 1.2 million. That's an 85% completion rate. The folks that have continued and renewed at the same benefit level is at 83%. Some folks have experienced what we call a benefit reduction. That could be that they were in a higher echelon of program. They've moved now to a different one. And that's a pretty small percentage, just 15,000 folks at 1.2%. And then again, our reduction of those folks with benefits ending is at 15.1%. So jumping to the next slide, this is what our outgoing renewal types look like. So this is what we're asking of people during this is a breakdown of what we are asking people for during this process. So 1.3 million plus have come up for redetermination so far. That's 91.6% of our population. So 67% people renewed without action. That's that ex parte passive renewal group that I'm speaking to. So those are folks that just received a notice that said, you're approved and you don't have to do anything and except let us know if something changes. And then 21% are people who are sent requests for more information. That's an area where we've really tried to make a limit and make sure that we don't need to do that as much as possible. Because this is the area that creates the most follow-up work for our staff. Or I should say, not the most follow-up staff, because the next bubble is probably the one that creates the most work for our staff, and that's people that we needed a full renewal for. That's an entire application, and that's going to be a lot more information. And then a small percentage we have identified as receiving an automated closure. Lots of that's income-driven. They're just simply overall of our FPL. Our federal poverty limit thresholds. So any questions about those last set of slides before we move to the next one?
We have a question from Tony German.
Hi, can you guys hear me? All right, excellent. Sorry about the difficulties with my Zoom this morning. It's great to be here with you all and Israel, and thank you for the presentation. And I agree with Ms. Jeffries. It has been a phenomenal piece of work that OHA has done, and just a remarkable effort to maintain continuity. And this means such a great deal. So I have a comment and a question. So I work for Fairly Quality Health Center, largely serve Medicaid population. This makes a big difference for people's health outcomes. And so just a really appreciative of that, of changing people's lives on the ground. So I've seen just a number of people that have maintained the continuity of care and not have that disjointedness with getting off Medicaid, getting back on, and seeing the merits of that. The one question I did have is in reference to the disenrollment. And I was curious about the percentage that have been able to flip onto the marketplace. Do we have data of those that have not qualified for continuous enrollment with OHP, those that have the percentage that have gone on to achieve marketplace insurance for themselves versus those that have been uninsured?
So I believe we do have some data. Excuse me. I don't think there's anyone from the marketplace team with us right this second, and I don't think there's anything in the slides. If you're okay with this suggestion, what we could do is plan for a little presentation next month that really kind of shows what life is like after OHP and what the enrollment, what the success has been for the folks who are working on that marketplace side. Is that something is a reasonable timeline for you?
Yeah, and I know I'm putting you on the spot with asking for data that isn't available on these. So, but I appreciate that. I think it would be helpful.
No, I think this is a great opportunity to do that, especially in advance of the summer. Some of those folks that are in those ex parte groups, may also experience that transition into the marketplace. So I think it would be a great time to kind of look at that and get some information. So we'll take that as a takeaway for next month for sure. Okay, so let's go ahead and jump to
Just a quick note for clarification. Sorry, just a quick note for clarification. We don't meet in March, but we'll meet on April 17th.
I think that's going to be just fine, because my recollection is that we have data about the number of people referred to Marketplace, but actually knowing the outcomes of that has been more of a challenge. So we'll be able to at least provide an explanation about what the challenges are.
Yeah, that's a good point. We don't have access to all data from other insurers and kind of where folks may decide to go on their own. But we can give you a very good idea about what we're doing in that referral process and how many people we've interacted with and what we're trying to do there. Okay, let's go ahead and pop forward a slide. Oh, this is just for your own use. This is just a quick QR code that you can jump to our dashboards. I will say a quick note about this. There are some efforts. The dashboard was built for a very specific set of time. And so one of the things that we're working on in the background with our teams is to expand the timelines now, since we've approved and we've adjusted when some of the folks are being asked. So the timeline on the dashboard was really meant to fulfill through April. And since we've expanded that, there has been some adjustments that we're working on in the background. So you may see some sections that have denote. You may see some sections that denote that they're not refreshed or properly updated yet, but we are getting very close to that. So keep that in mind when you look through that. That if you see a couple asterisks, those are things that we have in motion. But very good dashboards. Highly recommend them for overviews and getting very specific around even regions and other details like that. Okay, let's go ahead and jump one more. So just a quick at a glance of some of the steps that we have taken to preserve coverage, and a reminder for folks that if this is these are kind of our main tenets that we've been operating under. One is trying to be mindful of sequencing renewals. I think I've spoken about that with the previous timeline, so that should probably be very self-evident. Second, automating renewals. There's a lot of things that happen automatically. You can see the results of that from the folks that are automatically renewed. I'd say it's both the member time and our workforce time, and very critical to parts of our success. And then, of course, extending the timelines for response and closure. A lot of those pieces have really helped us maintain and keep our arms wrapped around people, and giving them extra time to respond. Life can come at our members and anyone fast, and so sometimes those things can slip away, and making sure they have some extra time to respond is really key. I do want to remind folks too, some people have asked if the 90-day reconsideration period will be going away once the public health emergency ends. And I just want to remind folks that is not part of the public health emergency. That's just a cool thing Oregon does. So we will continue to do that cool thing even after the public health emergency ends. The other piece is coming up, and I know that Laurel and Tim have been through here before, but it's the upcoming OHP Bridge program. That's going to happen in July. And it's going to be another way that we can cover adults in a higher FPL threshold. that they're currently being supported in through a temporary Medicaid expansion. This will allow an opportunity for them to continue to receive that care if they qualify based on income. I'm not going to spoil any of their major details. They'll be back in a future presentation, and I also don't want to misspeak on what they're up to. As the next one is around outreach efforts, and that's something that I spoke about. Well, we're going to come back with some other updates around that in the next couple of months. But there are ongoing outreach efforts. We have also confirmed that we're going to continue to partner with a contracted group called Met Group to help produce advertisements and supplies for partners, CCOs, anyone who is engaged in parts of the public health emergency unwinding. Especially one of the things that we're focusing on in this next run too is making sure that we're attempting to reach out successfully to some of our houseless populations. And so an example is that Met Group created some waterproof materials. So if you're handing out a card to somebody who may be upcoming renewal, that's something that may stick around a little bit longer as it's applied. So ideas like that. And then lastly, the new continuous eligibility rules that reduce attrition between renewals. But this allows for longer periods of enrollment before needing to renew in the future. So that's kind of a quick snapshot there. Let's go ahead and jump forward. Okay, this is going to give you a little bit more details about that final group. I might not dwell on every aspect here, but let's go ahead one more. I might have stolen the thunder from my own section here. So this gives you a little bit more details. This is the final group that this is referring to that begins in June. The last half of that timeline that was approved by our federal partners. Most of these members again are part of the supplemental income program. There's different numbers, and if they haven't closed, we restored and then rescheduled.
David, I'm so sorry. You're somehow you've got that underwater sound going on with your mic. I don't know if maybe you can be a little closer to it.
Did it come back or?
Oh, that's much better.
Okay, yeah. I'll be one of these guys.
It's okay. We appreciate it.
Sure, absolutely. And then this just details a little bit about our CMS approval that we received on February 13th. That gives you that our permission to do our staggered approach and that initial timeline that you can check out in the deck. So let's go ahead and jump forward one more. This is a breakdown of specifically. So the first timeline that you saw is a master timeline. That's the entire world, the entire universe of OHP. This is just highlighting the extended renewal timeline. So you can see on the left here, it starts with June, July, August, September, and you can see how it all lines up. These are our last final period. This is our last final runway for folks. And the 60-day adverse period on the bottom, lining up with February 2025. And so that is the last time that we will have the extended response periods and closure periods available. And then again, you can see the 90-day reconsideration period rolls right past February, again, because that is a standard, not an exception that's based on the public health emergency. So let's go ahead and move forward. So adjustments made to improve support during the final phase. Let's go one more. So we have some system and process upgrades that are scheduled for May. These have to be done in advance of that June timeline. So a single renewal notice is replacing passive and actual renewal notices. We'll no longer be using the renewal packet as it exists today. And this is based on a number of sources, some of them federal, and the needs to change some of this information. Along those lines is some notice improvements, more focus on types of benefits that are changing and the reasons for decisions. The design makes content easier to navigate. I will say that a huge improvement on our notices took place a couple of years ago. It was a massive effort across all of our agencies and divisions and units to kind of really revamp this. And here we are revamping it again. I've always considered these kinds of projects, like improving our notices, to be a perpetual practice. My dad used to tell me this, and I don't know if this is true, so don't get mad at my dad if it's not, but he used to tell me that they are always painting the Golden Gate Bridge, because the minute you're done with it, it's weathered enough at the beginning to you have to restart. And I really think about that a lot with some of these improvement processes that we have, especially around notices. We can never probably stop renewing these and making them more accessible, speaking to the member in a way that they understand better, all kinds of things like that. Finally, one, eligibility system changes. Again, we have some system issues that needed to be updated so we can handle the passive renewals individually instead of at a case-by-case level. This will also create a new challenge for our staff. I really want to advocate for them, and that their system is being updated as well. That they're going to have to learn a new process and a new way to do the work that they do at the same time. So really keeping them in our minds as we move forward. That they're facing another challenge after a series of challenges that they've really risen to. So we've got a lot of plans and training that will coincide with that, of course, but just want to advocate and mention that piece. Okay, let's go ahead and jump forward one more. Outreach and communication priorities. So we're going to continue supporting people in the renewal process. We're going to increase outreach to groups that are responding less to information requests. One of the things that we've tried to really analyze is our non-response information. Really helping us kind of prioritize certain areas. Like we know some things to be true, and we have found, through the non-response data, some other information to help drive our decision making, and help us be a little bit more precise. And one of the things that we discovered, for instance, was that we had quite a bit of houseless youth in parts of the southern area of our state that had a higher non-response rate than some other even metropolitan areas. So we're really working with some of our folks in the southern state to say, hey, what can we do differently or additionally to help those folks? That's just an example. You can see some other examples here too listed as well. I saw maybe a question go by. Maybe my pal Jillian can answer this one a little bit better than I. Jillian, you do a question?
Absolutely. So the question in the chat is, what does it mean that the one system will handle automatic renewals individually instead of by case? And so what was clarified for us by CMS is that when evaluating if somebody can be passively renewed, and Hillary, if I'm talking out the side of my head, okay. When evaluating if an individual can be passively renewed, we actually have to look at every individual and not every case. So a case could include an entire family. And so we were not taking that approach. And in order to do that, we have to update the system to allow us to look at every individual to identify for passive renewal rather than the entire household or the case.
Thank you. And Jillian, just to clarify, that would mean perhaps it would help with the scenario where we had a parent who get different employment, made more money, but their child would still be eligible. So if you did it individually, you would capture that. If you did it by case, the child might be removed from the plan. Is that kind of a correct?
So sort of, right? Like if it looks at the case and it says, this parent you can't do an ex parte renewal, right? A passive renewal for this parent. Therefore, we're going to have the entire case reapply instead of just renewing the child. And so then there's a risk that someone doesn't reapply and then they're denied for not going through that process and lose insurance when they shouldn't have.
Yeah.
And Hillary, who is part of your committee, is, I believe, providing some updates, and we'll go into more detail and probably speak much more eloquently to it in a little bit than I could.
Thank you. That gives people just a heads up about what to think about. So I appreciate that.
Absolutely.
Okay, great. So let's go ahead and jump up a slide.
Excellent.
I think that's the end of our presentation for this meeting. Again, you know, our feedback is always welcome. We have a really great feedback team that's collecting and raising those issues that we receive in that space. So feel free to use that often and as needed. And it's just another reiteration of our goal around feedback is to funnel those into a single location. It really has been helping us prioritize and be able to resolve these issues as we go. So yeah, so that's what we have for this month.
All right. Okay, well, thank you so much, David and Jillian. Really, really appreciated. Excellent presentation, all the information update, and as mentioned, the excellent work that your team is doing, especially around just continuous improvement and really trying to refine and improve constantly. So we really, really appreciate that about the team, and your work is showing an excellent outcomes. So thank you for that. So
I just maybe one last thing. I'm so sorry. I also wanted to say that, you know, someone said that OHA's efforts have really paid off. I really want to ring the bell that ODHS and OHA have really partnered, I think, and collaborated in a way that we have not always successfully done. And I think that we've really found a way that's different, that's honest, and really trying to grab some of the problems that we don't like, that we think members haven't enjoyed, and really tried to make some changes. We still got lots to do that can be improved, but it's really been such a collaborative group effort between both agencies, and I've enjoyed it so much. And I see Jillian threw a heart up there. You know, I think we both enjoyed it a lot. So I just want to advocate for that part too. That it's really been a group effort.
Oh, thank you, David. And I think that's important to note, just for the public understanding, as this is a public meeting, that this kind of work is often really complicated. So thank you for saying kudos to each other as partners, because those of us out in the community don't always necessarily understand how complex it is and how different parts of the work sit in totally different divisions with totally different staff, and that you have to take extra time to really coordinate your processes between those two entities and your teams, even though for those of us out in the field, we're like, what, it's one person, it should be more simple. Well, it's not. Unfortunately, we've made a complex system and it's not always so simple. So I appreciate you pointing out to people. So with that, I think we have a few questions. We have about 2 or 3 minutes. Look at us, we're staying on schedule. Woo-hoo, to answer some questions, please. Oh, Caroline.
Hi, I just wanted to express I'm also a family physician like Dr. German, and I work with him part of the time and also do primary care at OHSU. And a patient of mine a few months ago was sobbing in the office because she thought she was losing her OHP and wouldn't be able to come get her care anymore. And then I saw her about a month later, just with complete relief of knowing that she got renewed and was able to keep her care. So this work does make incredible difference. So thank you for helping these patients keep their care.
So thank you for sharing that story. It really helps keep us going on this side too. We work a lot on the problems, you know, which is our job, and very, very rightfully so. So I really love hearing that the things that are working well. Even when somebody hits that relief, I just find that so rewarding. So
it's really powerful to hear, and it genuinely makes a difference in people that I see every day.
It really fills you up when you know that folks are, you know, have that sense of relief and security. So thank you.
All right, well, thank you. Are there any further questions before we wrap up from committee members? Okay, well, with that, we look forward to your next presentation. David and Jillian, we really appreciate your time with us here today. Thank you so much. And I would like to make an administrative note. I do see that our committee member Shannon Buck, for the record, has joined the meeting for our attendance and quorum documentation. Thank you. All right. So with that, let's go ahead and move to our OHA ODHS update. Last month, we heard from AWEB about OHA initiatives. This month, we're going to focus on the ODHS work that touches Medicaid consumers with our new representative. We're so excited. So Max ODHS representative, as I mentioned, Hillary Thompson, is going to do her first official report out to our committee. So welcome, Hillary. I know that we're going to talk about one customer service center, statewide eligibility work updates, a little more information about that ex parte medical renewals that we just heard about, and updates on medical notices and Oregon Project Independence. So with that little teaser, Hillary, are you prepared and ready?
I am ready for my first official report out.
All right.
Sounds so fancy.
I know.
Yes, I think we can move forward in the slides, please. So good morning, I am Hillary Thompson, she, her, hers, and again, I am a policy analyst with the Oregon Department of Human Services, Aging and People with Disabilities, Medicaid Financial Eligibility Policy Team. That is a mouthful. I'm here to give a few updates on current happenings with ODHS. So we'll talk about some data around statewide eligibility work, go into some more details on the changes to the ex parte, also known as passive or automatic medical renewals that David was just talking about. And then some updates that we've made to medical notices as a part of that effort. And then talk a little bit about a new program that we're working on, Oregon Project Independence Medicaid, or OPIM. Next slide, please. So I wanted to take a minute to share some of numbers around just the absolute staggering immensity of the work that our ODHS staff is doing every day. I apologize that for the format of this, I just got this data last night and I didn't have time to make it look pretty. But still wanted to share the information because I think that really helps to illustrate the work that our staff is doing. Oh, sorry, can we go back?
Yeah, I'm sorry.
That's okay, thank you. So this data is for February 1st through the 25th of this year. We have answered statewide 54,582 calls with an average wait time from to connect a person with a worker is about 13 and a half minutes. We've completed roughly 25 or 24,000 appointments. That would be somebody calling with questions to report a change or to newly apply, maybe complete their renewal. These appointments are normally about an hour long, so multiply that by 24,000. They also serve as an opportunity for ODH staff to provide some Medicare, Medicaid choice counseling, CCO choice counseling, connect them to community resources, and then of course for the person to be able to ask questions. We've processed roughly 44,000 applications. In the lines below, you can see how those applications were received. So mostly in person and using our online applicant portal to apply for benefits. And then the other sources on the bottom line there, that's 6,725, that includes things like applications received by fax, email, or mail, or maybe at our local drop boxes. We have currently 86,237 pending tasks. Those tasks include new applications. They could also include renewals, SNAP periodic reports, information received when somebody is reporting a change or responding to a request for information that we sent, or tasks are also created when our automated interfaces receive information that require an eligibility worker to manually go in and review and update the case. As a win, February is the first time since August of 2023 that our pending tasks have been under 90,000. And I know that sounds like a very big number, and it is. And I really just wanted to use this data to really illustrate the work that our eligibility staff is doing. And next slide, please. So I did want to expand a little bit on the ex parte, also known as passive or automatic renewals that David touched on earlier. So in August of 2023, right around the beginning of the COVID-19 public health emergency unwinding period, the Centers for Medicare and Medicaid Services, or CMS, informed 30 states, including Oregon, that they had become aware of systematic and procedural issues for how medical renewals were being conducted, resulting in medical coverage inappropriately ending and especially negatively impacting children. So CMS issued a letter to state Medicaid directors informing states that medical renewals have to be completed on an individual and not a case basis, especially when there are, this especially impacts cases where there are multiple people included on the case. So ex parte renewals must also be attempted using information that the agency has available, including through our digital interfaces, before asking the person to provide information. So in Oregon, we currently complete renewals on a case level. And what that means is if one person on the case cannot be passively renewed, meaning that we are able to bounce their information off of our electronic interfaces and completely renew their medical without them having to do anything. If one person on the case is not able to be passively renewed, a renewal packet is sent to the head of household to complete and return for everybody on the case. So this is also referred to as active renewal. If the renewal packet is not returned, medical coverage ends for everyone on the case, even if it was only one person on the case that caused the whole case to go through that active renewal process. So even if just one person was not able to be passively renewed, we would send the whole case through that active renewal process. And this is what CMS is telling us is incorrect. So things that might require an active renewal based on our current one system functionality are things like if someone on the case is evaluated for a benefit that has a resource test, if there is a current override on the case, or if the case is in pending, the case itself is in pending status when it starts going through that renewal process. The vast majority of cases in Oregon are completed and renewed going through that passive renewal track. And it's important to note that these changes don't change anything about the way eligibility for medical programs is actually determined. It's really only about the renewal processes themselves. So CMS required states to take a few actions to correct the renewal process, pause medical closures when the case would have closed because of incorrect processes, restore medical coverage for anybody who was incorrectly closed, and then ultimately fix our systems and processes to prevent this from happening in the future. And next slide, please. So Oregon quickly followed CMS's requirements and got to work not only with the mitigation plan, restoring medical coverage and stopping incorrect closures, but developing systematic and procedural fixes for long-term solutions to align with CMS's expectations and requirements around medical renewals. These include not only completing renewals at the individual level, but if the person cannot be passively renewed, a renewal packet is mailed letting them know that more information is needed to determine their eligibility, gives them a summary of information we have on their case that they can either confirm or contest, and then asks for a signature to attest to the validity, excuse me, of the information that they provide. In addition, instead of taking a negative action on a medical case like a closure or reduction, and then informing the person of the decision, we're sending a notice letting them know that based on the information we have, they're not eligible for their current program and their coverage will either end or be reduced, while also providing them an opportunity to confirm the information we have is correct using their signature. So being more proactive about asking them to actually confirm that the information that we have is correct before taking any kind of negative action. So for example, if somebody is going from a full OHP plus coverage to maybe a standalone Medicare savings program, we'll send them a notice with a summary of the case information and ask them to confirm that that information is correct and up to date before their benefits are reduced. Design is in the final stages as we speak, and we expect for these long-term solutions to be in place in May of 2024. And next slide, please. As a part of these efforts, medical notices were also updated to make it more clear to people what their eligibility decision is and how that decision was determined in plain language. ODHS has heard loud and clear that our notices are difficult to understand. They don't provide enough information for the person to know what medical coverage they were approved or denied for and how we reached that eligibility decision. So we really used this as an opportunity to work with CMS's digital solutions division to update our renewal and our eligibility notices. As a part of that, we consolidated multiple renewal notices into one comprehensive notice, which will clearly communicate eligibility results for everyone on the case. If we were able to reach an eligibility result through the passive renewal process, and if we weren't, what actions we need the person to take to complete their renewal. So this could mean something like maybe they need to do an interview, or we need them to provide some kind of proof of information so that we can determine eligibility, usually things like income or resources. The updated notices will also include benefit summaries to explain medical benefits like organ health plan, Medicare savings program, and sometimes some of our dental only programs, so that the person knows the basics of what's actually included in that medical coverage. They will also include detailed, individualized information on what criteria was used to determine their eligibility, including specific subsections of the organ administrative rules or OARs that were used. So for example, instead of just saying you have countable income over program limits, the updated notice will tell the person how much income we're counting, what the program limit is, and then what specific part of that organ administrative rule has that information. We also wanted to make it easier for people to find information in their notice about how to request an administrative hearing. So that information was moved right up to the beginning of the notice instead of where it historically has been towards the end. CMS requires us to review eligibility for all medical programs, which is done automatically in our integrated one system, but our current notices don't make that very clear. So we've added information to let the person know we looked at every medical program available, and if they think they might be eligible for something, to please let us know. We've also gotten feedback about the patient liability portion of our eligibility notices, which don't make it clear that room and board payments are included in the patient liability calculation. So patient liability is the amount that a person receiving long-term services and supports in a community-based or nursing facility has to pay each month to contribute towards the cost of their care. It's determined by their individual gross income and then any allowable expenses that they might have. When people are living in a community-based facility, like a assisted living facility, adult foster home, residential care facility, the room and board standard is used as an income deduction to reduce their liability because it's a separate payment that they make to the facility. but none of that was very clear on our notices before. So we've updated our notice to make it more clear that the room and board payment might be due to the facility and that it's already been considered in their calculation, in their liability calculation. We're very excited about these enhancements to our notices and really believe that it's a step towards greater transparency and understanding in the medical eligibility process. And next slide, please. Other exciting news within ODHS is the very recent, within the last couple of weeks, approval of the 1115 demonstration waiver to federally fund limited in-home services to older adults, people experiencing Alzheimer's disease or related disorders, and younger adults with physical disabilities through Oregon Project Independence Medicaid, or OPIM. OPI, not OPIM, but OPI has been around since the 70s, but it's only funded through the Oregon legislature. The level of state funding for OPI has really fluctuated over the years, which has caused waiting lists in many areas and sometimes closures due to lack of funding. So this demonstration waiver really provides an opportunity for program stability through that federal matching and then expanded supports for eligible adults. The goal of OPI and OPIM is to provide limited in-home supports to older adults and younger adults living with disabilities to promote independence and well-being while also delaying the need for Medicaid long-term services and supports. To be eligible for OPIM, the individual has to be aged 18 or over, have individual income at or below 400% of the federal poverty level, and resources up to the average cost of 6 months in a nursing facility. And that nursing facility is based on the Medicaid rate. They also need to meet citizenship and immigration requirements for Medicaid, and then be assessed by a case manager or have personal care needs that fall within the range of a service priority level, or SPL, 1 through 18, with 1 being the very highest level of care. One of the things that's very exciting about OPIM is that OPIM is not going to be subject to estate recovery claims. So participants can pass on assets from their estate to their families without having to worry about the state recovering up to what it paid for the cost of their care. And this is really going to help address inherited wealth gaps, especially impacting priority populations. People will start to receive their case management through area agencies on aging, or AAAs, and financial eligibility for OPIM is going to be determined by ODHS Aging and People with Disabilities, or APD, eligibility case managers. There is a soft rollout plan for OPIM, but as of now, the start date is to be determined while the rules are still being written and finalized. And next slide, please. So this is just a little table here to explain some of the differences between OPI, which is our current program, and then OPIM that adds that Medicaid funding. There are some major differences. The nice thing about having OPIM being funded through Medicaid is that this really is going to open the door to provide a wider array of services that aren't possible or may vary depending on area with limited state OPI funding. So people on OPIM will be able to get additional supports like emergency response systems to quickly contact emergency case services in case of a fall or an accident, transportation, in-home long-term community care nursing, home modifications, adult day services, and assistive technology. A major difference between OPI and OPIM, besides the funding, are the income and resource limits. So OPI does not have an income or resource limit, whereas OPIM has both, but the limits for OPIM are still higher than our Medicaid standards. Another major difference is that people on OPI cannot have full Medicaid coverage, whereas people with OPIM can, as long as they still meet that financial and non-financial eligibility criteria for Medicaid. And I think that's it. I believe I included a reference slide. Yeah. So here you can see that first line there is the letter that CMS sent to state Medicaid directors. There's some more information in that second link about states' mitigation plans, and then some more information and frequently asked questions about OPIM. Thank you.
Thank you, Hillary. That was really informative. I'm going to open the floor to questions, but I did have a quick question on the new OPIM plan. Are you at the point yet in the waiver where you have more specifics on some of the services, or if there's a minimum amount of services that have to be received? I know that there's some interesting things around how services are delivered in the system to folks who have Alzheimer's, particularly who are living at home with their spouse who is does not have Alzheimer's, so that spouse is really the caretaker. Like you need a certain amount of services before the services will be funded, or et cetera. And sometimes periodic respite services are hard to get funded for folks in that situation, even though they maybe don't need a daily service. So just curious if there will be details coming out about that, or if you have some already.
That's a great question. So I think what you're alluding to is that traditional Medicaid long-term services and supports, the recipient has to have fairly high care needs in order for the state to allow their spouse to be a paid caregiver. I am not sure offhand if that is going to be allowable or considered with OPIM, but I am happy to take that back to the policy lead and check with them. I do know that OPIM is going to be limited to 40 in-home service hours per pay period. So that's every 2 weeks. So roughly, depending on how it's scheduled out, about 20 hours a week of in-home services. Traditional OPI, so our current state-funded OPI, is also fairly limited in its number of service hours that's available. But I'm not sure offhand if it's been figured out yet if the spouse would be allowed to be a paid caregiver. Am I interpreting your question correctly?
You're getting the nuances, I guess.
Okay.
that yes. So thank you for that, because I know it's complex, and I guess that was kind of the bigger question: is does it remove some of those complexities for folks so that they can stay at home longer and perhaps even get services earlier when their acuity is a little bit lower, but is still quite exhaustive for family members to do on their own. Yeah, absolutely. So yeah, you were getting it. Thank you. I appreciate that. So
no problem, and I'm happy to take that back and get an answer for you.
Great. Do we have any questions? Oh, Lisa, go ahead.
Yeah, is there a timeline for rolling out the new OPIM service provisions?
They are, so the waiver was just approved like a couple of weeks ago. And I know that the long-term services and supports policy team has really been taking the lead on these efforts. I believe they are in the final stages of drafting the rules. And then of course it will need to go through the RAC process and all of that. So tentatively planned for this summer. There is a plan to do kind of a soft rollout. So maybe not across and I don't have a lot of details on that, but I'm happy to get more information. But tentatively this summer, starting out that soft rollout process. There's in that third link here, there's a program comparison chart. There's some frequently asked questions that might be helpful. And so there might be some information in there.
Are there any further questions from Medicaid Advisory Committee members? All righty. Well, in seeing none, look at us, 10:09. We are doing excellent work. Thank you, presenters, and thank you, Medicaid committee members, for asking questions. We're just ticking along. So with that, our next update is the legislative update. So we are very fortunate to be joined by several members of the OHA's governmental relations team to update us on bills moving through the legislature, even right now as we speak, because we know it's that fast and furious short session. Is it roughly 35 days-ish or something? So we really, with that timeline and the time crunch and all the activity that's happening in the Medicaid and behavioral health and physical health space, we really appreciate our team's time here with us today. So I know that we have Matthew Green, Philip Schmidt, and Robert Lee were planning to join us. I'm not sure, because I can't see everybody, who of those
We're
three
here.
folks are here.
We're here.
Oh, wonderful.
Yep.
So with that, I'll give you the floor. Thank you.
Hey all, Philip Schmidt, I use he, him pronouns. I'm on the government relations team for OHA. And you actually are in for a treat because our whole team is here, which just due to the vagaries of scheduling is surprising because as the chair just said, we're in the middle of legislative session. Lots has happened. I'm just going to sort of kick us off and then I'm going to turn it over to teammates and we're going to kind of race through quite a few different bills. So two items to note, and having the front of your brains as you're hearing from us. First is all the bills, except for I think maybe one or two, are still in the process, as your chair noted. So we're not reporting on bills that have passed or that are, we're not prognosticating on their likelihood of passage, that sort of thing. We're just giving you an update about what these important bills do, so that you're aware of them. And we'll be happy to come back after a legislative session and report more fully on what did happen and what did pass. The second item is that I think with one exception, OHA has no position on any of these bills. So again, we're just sort of reporting the facts and not indicating in any way, hopefully through our commentary, any support or opposition to bills. We have no position. So as the chair noted, the behavioral health, the opioid crisis has sort of taken the front seat in this legislative session. So I'm going to turn it over to colleagues who've been really closely tracking and working on the bills that are sort of front and center on that topic. So I think Matthew will.
And I think that's me. Yeah.
Thanks.
So hello, I'm Matthew Green, another member of the government relations team, he, him. And so the big one that's getting all the attention, deservedly so, I think, is 4002. It's been referred to as the Measure 110 bill, but it's really not. It's something, it touches on Measure 110, but it gets into a lot of other issues. You can broadly define it, or you split it into two halves, the health half and the criminal justice half. On the criminal justice side, which we have a much less to do with, we're not heavily involved in that side. It does recriminalize possession of small amounts of controlled substances, and it sets up what's known as a deflection program, or at least the opportunity for local communities, for counties to set up deflection programs, which are a variation on sort of the diversion, alternative sentencing kind of thing, where people can get treatment and if they successfully go through that, any charges are waived. And by the way, that should be HB 4002. I think that's my typo. On the health side, there's a lot more that you're probably interested in that we're involved in. There's a bunch of clauses on a variety of things, very little of which actually affects the health clauses that were originally in Measure 110. Those, the behavioral health resource networks, basically untouched, but I'll run through some other ones really quick. Prior authorization section, prohibiting prior authorization or utilization review for medicine-assisted treatment for SUD, for substance use. The idea is to eliminate the initial barrier of getting someone started on an MAT. It applies both to private payers and as well as to CCOs. There's different clauses for both. There's a section on pharmacists that allows what they call early refills, basically sort of an emergency measure to make sure people can get SUD treatment medications very quickly. Also, a thing called prescription lockers that exist, I think, in some other states, and they're trying them out here specifically for the purpose of making it quicker and easier to dispense SUD medications. There is a clause about network adequacy of CCOs. It is pretty mild and vague. It doesn't do a lot of practical changes. It definitely expresses an intent to do more about network adequacy regarding SUD treatment, although it doesn't do a great deal. One significant item is the extension of certified community behavioral health clinics. Right now, we have demonstration programs of those clinics in a number of counties, but certainly not statewide. This would set up the opportunity for them to go statewide to provide a greater safety net for people on behavioral health in general, SUD and other issues. They need to collaborate with community mental health programs. They would have to follow federal rules about CCBHCs and so forth, but the basic idea is extended statewide. There are a few other things like a little extension of welfare holds about that allowing crisis response workers, mobile crisis response to take people to sobering facilities, things like that. There's some grants for SUD treatment in local correctional facilities and other smaller items, but those are the big ones. That passed out of committee, the Special Addiction and Community Safety Committee, last night, not quite unanimously, but close to it. And it goes on to the floor of the House and Senate right now. There's also a competing bill that Republican legislators had proposed, and that actually yesterday came up, and there was an attempt to bring it to the floor of the House that got very close. So it's really still an interesting political debate going on. The last two bills here are much briefer. The 1553 is specifically about criminalizing substance use on public transit. That is going through almost unanimously. There is 4011, which is actually an omnibus bill. There's several items, but one piece of it is harm reduction clearinghouse that formalized and codifying an existing program with the idea of potentially putting some more money into it, particularly for Narcan and other things. Those are the big ones. There's a variety of other bills around this general topic that aren't moving. Those are the ones that are actually moving. So I think that's the end of this section. Turn over to who's doing the next slide? Looks like Robert.
Looks like me. Good afternoon or good morning, everyone. Robert Lee. Pronouns that I use he, him, his, and I have the behavioral health portfolio. Wanted to share with you a couple of the bills that we're really working this session regarding behavioral health. One you may have heard of is Senate Bill 1557, the culture of yes, related to services to individuals under age 21. Measure mandates basically Oregon Health Authority to provide services and supports to individuals under 21 in Oregon using funding from Community First Choice Option. Clarifies that individuals under 21 should not be turned away from mental health services just because they have an intellectual or developmental disability. It places additional requirements for Oregon Health Authority to collaborate with ODHS and our partners, as well as families and youth with lived experience to investigate services and supports provided to individuals under the age of 21 that are funded through the K plan and provided to avoid out-of-home placements of child or youth. Senate Bill 1522 that repeals statutes related to IDD commitments. So basically, it repeals the statutes around civil commitments of individuals with intellectual disabilities who are also approved for services as provided by ODHS and Office of Developmental Disabilities. Changes the definition a person with mental illness to include persons who also lives with intellectual disabilities. Also prohibits the denial of mental health services on the basis that the person has an intellectual disability. 4087, this is also known as the Emergency High Acuity Youth Initiative. It's had a few different names since its inception, but basically it establishes a pilot program to expand residential treatments or residential systems of care for certain children and youth by issuing capacity payments to providers. So they would have not in lieu of, but in addition to payments to provide stability services and stability payments. Measure requires a System of Care Advisory Council, or SOCAC, to report to the legislature and authorizes rulemaking by Oregon Health Authority, ODHS, OIA. And I think it's still appropriating $15 million for that, for the total. House Bill 4092, that's a cost study and task force to review basically our CMHPs, or community mental health programs, and convene a group of behavioral health partners to evaluate laws, rules, and contracts affecting behavioral health providers throughout the state. And it also includes substance use disorder programs. The 1594 creates a task force on improving the safety of behavioral health workers, appropriates a certain amount of money. It's about $4.7 million to the Oregon Health Authority to support behavioral health apprenticeships and training programs. And it also appropriates another about $1 million to United We Heal Trust Fund for grants to improve the safety of workers in behavioral health settings. And then 4070 expands funding for school-based health centers. So expands for inflation, also requires Oregon Health Authority in consultation with Department of Education to select 10 different school districts or education service districts, or ESDs, to receive grants for the planning and operation of school-based health services centers. It does require Oregon Health Authority to study methods for providing and increasing reimbursements for mental health services delivered through school-based health centers under the Oregon Health Plan. And next.
Thanks, and I want to acknowledge that we're running short on time. We are gonna speed through the next few slides. If we could go to the next one. I think I'm gonna actually skip this slide because there's not actually too many Medicaid implications. Again, happy to come back later. And I'll turn it over to my colleague, M. Droege, who will do a couple of the bills on the public health side, including one that we support.
Thanks, Phil. Hi, everyone. My name is M. Droege. I use she and they pronouns. I'm on the GR team at Oregon Health Authority. I will speak to just a couple of these bills because we're running short on time. I'll start with House Bill 4081, which is the one bill this session that Oregon Health Authority has a position on, and we're in support of this bill. This is the Emergency Medical Services Modernization Bill. It restructures existing advisory boards and committees within Oregon Health Authority, and it also establishes the Emergency Medical Systems Advisory Board to develop a comprehensive emergency medical services system in the state of Oregon. Gosh, there was a lot of systems in that sentence. I'll also speak to House Bill 4105. This is the Nurse Family Partnerships bill. This is Representative Reynolds' bill. It appropriates funding to Oregon Health Authority for the non-federal share of public funds for Medicaid reimbursement for targeted case management services provided by the Nurse Family Partnership Program. This eliminates the need for counties to contribute matching funds, and that is all I will say about that one. And then another high priority is House Bill 4136, which is in response to the Peace Health closure in Eugene. This one gives funding to Lane County for emergency and same day health services. It requires OHA to administer $4.5 million to Lane County Public Health for emergency and same day health services. And those are all the ones that I'll speak to for public health. We can move to the next slide.
Great. So these are a few bills that really directly impact the Oregon Health Plan. The first at the top is SB 1508, which indeed has passed both chambers and is headed to the governor for signature. It bans the use of quality adjusted life years, which is an econometric measurement tool that pops up in medical research. And it's there's wide agreement that quality adjusted life years actually is discriminatory towards people with disabilities. So this bill makes clear that the Health Evidence Review Commission, which makes treatment and service decisions about the Oregon Health Plan, that they cannot rely on any research that contains quality adjusted life years. It allows them to redact if there's references to it and ensure that they're getting access to the best evidence-based research in making their coverage decisions, but making sure that this discriminatory tool is weeded out from that consideration. So that's an important bill for health equity. We were happy to work with folks on that to move it forward. The bill also was amended to include a cap on insulin copays for folks that aren't on Medicaid and have copays. So that's important for folks that rely on insulin to manage their diabetes. Within another omnibus bill, there's coverage for cervical cancer screenings and a mandate that the Oregon Health Plan and other plans cover continuous glucose monitoring devices. The HERC had been considering continuous glucose monitoring devices, but this would mandate that they be covered. And I think if my colleague John English is on the line, might give you a quick overview of SB 1529. And I think we'll wrap after that and be happy to take questions.
Sure. Can you hear me okay? Thumbs up.
So far, so good.
Hi, everyone. John English, he, him, also a member of the government relations team. 1529 and 1530 are kind of paired together. 1529 is an extension of a bill that was passed in 2021. It allows OHA to distribute air conditioners and air filtration devices to individuals, importantly, in advance of a heat or wildfire emergency. That's one of the limitations that we've run into under the 1115 waiver, the ability to provide things proactively. So that's an important piece to note in that bill. And then Senate Bill 1530 is essentially kind of a larger omnibus funding bill, if you will. And one of the sections in that bill is the mechanism that provides funding for the air conditioners. That amount is $3.5 million.
Yeah, thank you. I think the next slide, if I'm not mistaken, is just our contact information, or M, is it equity inclusion?
It is equity inclusion. Is it okay? Do we have time for me to speak to this one really quickly?
Please. Too important to skip.
Yeah, this one is really important and also related to Medicaid. Senate Bill 1578 directs Oregon Health Authority to establish and maintain an interpreter management system that allows for scheduling and billing of healthcare interpreters for Oregon Health Plan members. It also directs OHA to contract with a nonprofit to manage and administer a training and retention program for healthcare interpreters as well. That's all I'll say about that.
All right, if we could go to the next slide, I think. Yeah, so here's our contact information. We're available anytime for any questions you all have or input. So I think with that, we are happy to take any questions you have now about any of the bills we shared about. Yeah, appreciate you letting us fly through this so quickly.
Oh, thank you. So sorry, we had to unmute here in the room. Thank you so much, Philip and team. That was a great presentation. We have a couple minutes before we go into break, and we can always talk about these items later in the meeting. Oh, and Tony's got his hand up, so go ahead, Tony.
Well, thank you all for that great presentation. Quite a whirlwind in a short session, a lot going on, a lot of good items. I was curious to go back to House Bill 4028. This is in reference to 340B pricing for contract pharmacies. And I was just curious about the status of that. This involves having members be able to get medications, supporting a price that they're able to afford. And there's been some limitations on those contract pharmacies. And just wondering if that was proceeding or if it is being held up.
Thank you for the question. And yeah, that bill, as I understand it, is it's in Senate Committee on Rules, I believe, House Committee on Rules. And I just am not totally sure what the state of play is around whether it's going to move forward or not. Great. I think 340B is a very tangled corner of the world from a policy perspective. And so I do know we've been getting questions from lawmakers who want to understand how it affects Medicaid, how it affects Medicaid members. So we've been doing our best to answer those questions. But the amount of questions, I would say, is very indicative of the amount of confusion about how this plays out for all the different parties involved. So yeah, we'll have to check back in with you after the session and let you know what happened.
Right, thanks.
Appreciate the interest. It is an important program, and I do want to just recognize one of the areas that we've been asked to give information on. My colleague Em is giving some input to the lawmakers. I'll let you speak.
Yeah, I think there's a lot of misconceptions about the program that I think are being misconstrued. It really is an effective program, really supportive of being able to deliver care in communities of marginalized and underserved communities. So just really impressed upon people. The nature of that program is really helpful. So thank you for your work on that.
Yeah, we've been working really closely with folks in the public health division to provide educational information on legislators about the importance of that program specifically. So I appreciate you flagging that too, Tony.
Thank you, everyone, for the discussion on that one. I concur that access for our remote and rural communities could really be impacted if, depending on how that one comes out. So really important topic. I did want to highlight a couple other ones because we've had some pretty robust discussions here on the Medicaid Advisory Committee about administrative burden. In fact, it came up in an interesting way on our redetermination presentation today about reducing administrative burden and making processes more consumer plain language approachable, and streamlining documentation and other bureaucratic activities so that they're more consumer informed and trauma and culturally responsive. And so I do serve also on some administrative burden workforce groups for many, many months. And I know, again, that here in the advisory committee, we've talked about this a lot as a huge barrier to care and capacity building, particularly both in physical health, but particularly in behavioral health. And so I didn't really see that highlighted on HB 4092, and I just wanted to take a minute to say that it's much more than just CMHPs and other folks for the advisory members to understand exactly what is in the content of that and how important it is. So we'll be excited to hear how that goes in the session. And then maybe just one, I do see that there's two for youth system integration of supporting health services in schools. And I know that that's another really passionate topic here for folks on the Medicaid Advisory Committee, because we have such a lack of youth services and literally lack of youth service providers in the state of Oregon for many services, and that our access is really constrained for child and youth services in the state, particularly for behavioral health, though I do know there's constraints even on the physical health pediatric side. So I would love to learn more about that, and I know the Medicaid Advisory Committee will be very excited to hear about how those things go for youth system development, particularly about equitable access. So thank you very much. And again, Medicaid Advisory Committee members, if I've spurred some questions in my comments there, we will have time towards the end of the meeting to have further discussions. So hold that thought. Thank you, policy team, government team. It was wonderful to have you all here and meet you and hear about the excellent work that you're doing on education and information for our state legislature. Okay, so I think with that, we are good. Look at that, 10:34. It is now time for a break. So thank you for the discussion, and we will be back at 10. We try to 10:40, maybe 10:42. We'll give you a minute to take a little break.
Shall we call it 10:42 then?
Yeah, let's do that.
Okay, great.
Okay. All right, welcome back. I'm so sorry. I believe we needed a bio break and we're running it just a little bit behind, but it is time for us to recommence the Medicaid Advisory Committee meeting after our break. I hope you all had a good break. And our next upcoming presentation today for the Medicaid Advisory Committee is the 1115 Waiver Evaluation Design and Discussion. So as part of our ongoing commitment to contribute to Oregon's 1115 waivers, you know, there's many, this is the particularly large waiver. We have asked the contractor tasked with the design of the evaluation of that particular waiver to return for more additional discussion. And we really appreciate they've been coming every month and keeping us posted and taking our feedback as advisory members, because this is one of our Medicaid Advisory Committee federal requirements that we fulfill in really making sure that we're taking looks at waivers and giving input. So we appreciate the contractor's time in helping us fulfill this obligation as an advisory body. So this month, the Providence Core team, who is the consultant, Director Lisa Angus and Director Carrie, oh, I have to put my glasses on, I'm so sorry, Bartanian. Hopefully, Dr. Carey, I have not totally butchered your name. Join us to introduce and seek feedback on the health-related social needs evaluation questionnaire and draft questions. So thank you both. Are you both here and ready to present? And please correct my pronunciations. I would appreciate that.
Good morning. Yeah, we're both here, I think. Make sure Carrie is on. Yeah.
Yeah.
I'm going to start out just briefly. Hi, everyone. I'm Lisa Angus, she, her pronouns, and I have had the privilege of joining you before. And then Carrie's going to take over for the most of the substance of this presentation. We're glad to be with you. And thanks for that intro. Can I just double check on procedure? Is the idea that we go through and then pause for questions at the end, or MAC members, will you jump in as we go? Either way is fine with us.
Lisa, either way is fine with us. Thank you for letting us know that we are able to raise hand, and I'll try and watch for raised hands as people go along. Thank you.
Great, thank you. So as has already been said, the focus today is to dig into what we have as draft plans for evaluating the health-related social needs components of the waiver. So we'll do a little bit of super brief background, but that's the main topic for today. And we will close just with a reminder of where we are in the evaluation design timeline and some next steps. Excuse me. And as also has already been covered, we've been here a lot, and we're very grateful for the time you have given us. So this is the third month in a row that we're talking about the waiver evaluation. We talked in January about the youth with special healthcare needs and continuous eligibility components of the waiver, and now we're going to focus here on health-related social needs. Jumping forward. So one more slide, please. I think this is probably now familiar to the point of nausea for you all, but the overall goals on the waiver are here on the left: to advance health equity, to create a more equitable, culturally and linguistically responsive healthcare system, help people maintain coverage, improve health outcomes by addressing health-related social needs, and ensure sort of the continuation of the ability to do smart and flexible spending. And on the right are some of the waiver components that we've talked to you about before, and the health-related social needs one that is the focus for today. And just as a reminder, the waiver is currently ongoing. Different policies are starting at different dates, and the waiver runs through Q3 in 2027. Well, a couple more slides here. So health-related social needs, again, I think this isn't news, but these are sort of a bucket of social and economic needs that have an effect on individuals' ability to maintain their health and well-being. And Oregon has bucketed these in 4 buckets: climate supports, housing, nutrition supports, and then sort of a wraparound service set of services around outreach and care coordination. And as you can see on this slide, and probably already know, these are all starting on different dates. So climate supports are supposed to kick off almost next week. Housing supports are slated to begin in November of this year, and the nutrition ones in the beginning of 2025. And on the next slide, if we can jump to the next slide. Oh, there's some there are some specific funding components, both not only for the health related services, but grant funding to help build infrastructure and capacity to deliver those services, especially among community-based organizations and other groups already in the business of providing those kind of services. Do we have one more slide? Okay, just briefly, we had done a little bit of slide swapping out. If there are questions about what is actually covered under each of those health-related social needs categories, I have a little list that we can refer to in answering questions. It's not, that's always a good question for OHA staff, but if that's helpful, once we're getting to the discussion, we can flip back to that information. So at this point, oh, go ahead.
Oh, Lisa, this is Heather. That would be great if you can, we can share that with members offline or share it later on the actual services as they're getting more defined.
Yeah.
And then are you going to cover today too the population eligibility for the services? Has that been more defined as of yet, or is that still ongoing?
I believe it's still ongoing. It's not something we were going to cover in depth, although it is threaded through some of the questions we'd like to ask as part of evaluation, but we weren't going to dive into that in depth.
Okay, thank you. It's just your comment about which services made me think about that. I thought we still were not totally determined on population eligibility, and you have answered my question. We are not, so thank you.
Reasonably confident of that.
Yeah. Still in the process.
Yeah. Okay, I'm going to turn it over to Carrie, who is going to talk through what the draft plans are now around evaluation for this component of the waiver.
Great, thank you, Lisa, and you did a great job with my name, so thank you. To address the question that just came up about populations, there has been new information released about the different eligibility criteria for the populations receiving those different types of benefits, and there is variation across, and my understanding is, as this continues to get more defined, my guess is there will be some continued definition, but it does include a mix of social as well as clinical criteria and a lot of focus on transitioning populations. So today I'm going to talk about, to walk you through the evaluation questions and the approach. This is a high level summary, but there's still a lot of information. I will do more reading of slides than I typically do when presenting, because I really want to make sure all these details come across. So to begin, the questions we're going to talk about today are separated into implementation questions and more of the outcomes-based research questions. This is how CMS has also approached this, and I will say that these questions that we present today are all CMS requirements. So for the implementation questions, there were 7 questions required by CMS, but also sub-questions within that. So you'll see a lot of questions for us to present to you over the next 2 slides, covering everything from HRN service delivery infrastructure on this slide to some of the services and the contextual factors. So when it comes to the HRSN service delivery infrastructure, the questions include which key entities are collaborating to implement and operationalize the demonstration, and what are their main roles? What changes occur during the demonstration? What are barriers for key entities implementing the demonstration? What strategies are used to overcome barriers, and what are suggestions for improvements? What infrastructure are key entities developing or acquiring using demonstration funds? And what are the promising practices for building or sustaining infrastructure to support HRSN, the health-related social needs? How do key entities form and maintain organizational partnerships to promote integration of health and the health-related social needs services? And to what extent is the state integrating the demonstration with its existing programs and infrastructure? Next slide, please. So when it comes to screening, case management, and experience, the questions are, what strategies and tools do key entities use to identify beneficiaries with social risk factors and facilitate beneficiary participation in the demonstration? How are key entities implementing HRSN case management and providing the HRSN services through the demonstration? How, if at all, did the demonstration establish a process to share and receive screening results among key entities? What facilitators and barriers to participation did the beneficiaries experience? And then when it comes to questions about the context, there's questions about how is the local availability of an investment in social services outside of the demonstration changing during the demonstration project? And how is enrollment in SNAP and WIC changing during the demonstration? So you can see there's a lot of questions. And I think part of that really emphasizes how incredibly important implementation is for us to be able to really learn from this novel policy. So when it comes to the populations of interest for the implementation questions, these populations of interest are folks that would be part of the evaluation. We'd be looking at different types of key entities involved in planning and implementing and planning the HRSN services, the beneficiaries who are connected to the HRSN services by different methods. There's different ways in which members will be able to be screened and become eligible for the benefit, the different types of services that they're receiving, and they'll be looking at receiving services from different HRSN providers. The population obviously will be explored also by different demographics, as well as thinking about different service providers and geographies. Next slide, please. So the approach to the implementation questions are largely qualitative in nature, although there are some other types of data included. And sorry, I'm trying to check in on the chat as we go. Okay. So this design includes conducting longitudinal interviews with those key entities, as well as holding online asynchronous focus groups to continue to capture these lessons from implementations. And these lessons can include different roles, facilitators, barriers, lessons learned as the implementation is ongoing, as well as these targeted interviews with different entities participating in implementing the HRSN. The approach would also include interviews with the HRSN beneficiaries to learn about their experiences and barriers and facilitators to their receipt of those HRSN services. Conducting interviews with healthcare providers to understand how these benefits are potentially impacting their clinical practice. And then also this includes looking at a variety of other implementation data that may be available, such as different documents, CCO the reports from CCOs, data on the distribution of the infrastructure funding and so on, as well as some secondary data sources that may be really useful, such as looking at the concerns filed with OHA Ombuds program. There will be an environmental scan of the HRSN service availability to kind of understand those contextual questions that they were asking about, as well as looking at SNAP and WIC enrollment. That is the high-level summary of the implementation questions. I don't know if I should pause before we go to the outcomes and impact questions. Anything folks want to surface at this point? I will keep going.
Oh yeah, Keep
Okay.
going. You keep going. This is Heather. I have some questions, but I'm going to hold them because you might cover them. So.
Okay, great. So the second set of questions are focused more on different types of impacts. And so those questions are focusing on understanding how the demonstration has affected the use of HRSN services, the rates and severity of health-related social needs, and disparities in health-related social needs. There's also a question understanding how the receipt of HRSN benefits have impacted the use of healthcare, including preventive and hospital care, and how that impacts disparities in care. And finally, they want one of the requirements is also to explore how the receipt of the HRSN services have actually impacted beneficiary physical and mental health outcomes. And then again, of course, looking at disparities in those outcomes. Next slide, please. So I wanted to just pause on the potential outcomes of interest related to those questions. Here we've broken them down a little bit by the different types of services that could be provided, as well as some of the different outcomes of interest for the healthcare and health outcomes question. But I do want to say too that there will be kind of an overarching investigation into the amount of services provided, who's receiving those services, how many services people are receiving, the different types, the per member per year amount of services, and so on. So that kind of high level picture of the receipt of the HRSN services is definitely an outcome related to the questions that we have listed. But here we're talking more about some of the hypothesized expected outcomes related to the services that are being provided. So in terms of housing outcomes, thinking about housing stabilization, decreased occurrence of eviction, decreased mobility, moving around a lot, decreased utility shutoffs, because utilities services, financial support for utilities is one of the benefits, as well as decreased use of emergency shelters. For nutrition outcomes, this looks like stabilization, nutrition stabilization of food security, decreased skipping meals, decreased eating less because of lack of food, or decreased consumption of fast food, decreased use of emergency food banks. When it comes to some of the climate-specific outcomes, thinking about maintenance of temperature control and less pollution exposure, or decreased use of emergency shelters, as well as some of the types of uses of healthcare related to climate emergencies, such as decreased use of avoidable emergency care during climate emergencies, or decreased use of acute care for climate sensitive conditions. And then when we're looking at healthcare and health outcomes, that would be thinking about the potential for increased use of preventive and routine care. And I say in this bucket, this also includes behavioral health and dental care, decreased use of avoidable and emergency and acute care, increased continuity of care, looking at disparities in healthcare access, improves physical health, improve mental health, reduce stress, all mainly focused on self-report, improve chronic disease management, as well as improved oral health. Next slide, please. So the populations of interest here very much focus on the Medicaid beneficiaries who are receiving the HRSN services. And within that group, we'll be looking again across different sociodemographics. So looking again by the demographics listed here. We'll also be looking at beneficiaries receiving different kinds or amounts of HRSN services. There are a few potential comparison groups for certain aspects of these questions. As you all know, health-related social needs are not broadly collected for everyone, so there's not really a great source of data on that for the, even the general Medicaid population. So when we were thinking about a couple potential comparison groups, we've been thinking about the population who have been receiving flex services through CCOs for health-related needs, and thinking about how those services may be changing over time, looking at the kind of landscape of those services before and after the the implementation of the benefit. And then another potential comparison group of interest relates to the climate services, thinking about populations in different geographies prior to different geographies throughout Oregon who maybe experienced a climate crisis prior to the waiver versus populations experiencing a climate crisis in specific regions of Oregon after the HRSN benefit has been implemented. So those are a few comparison groups that we have been thinking about. Sorry, not all those words are on this slides. So there was a few updates that we weren't able to get into the deck in time, it looks like. So, next slide, please. So for the approach for these questions, this really is a strong mix of both qualitative and quantitative data. So for example, the evaluator would be analyzing Medicaid claims data for a variety of purposes. One, that's where you'll be able to see the receipt of HRSN services. So it'll be a really great resource to understand the different types of services that were received for the beneficiary, as well as looking at the impact of those services on healthcare utilization, including disparities. If it's available, it'd be great to be able to analyze the HRSN screening and authorization data to further understand who is and who is not being screened and authorized. There'll be interviews conducted with the HRSN beneficiaries to learn about their experience of receiving services, the impact of on their health-related service needs, and their experience of receiving the HRSN benefit even after it has been completed. This is also going to be a place to really explore impacts on their health and impacts on their healthcare access. These would be the same interviews as the beneficiary interviews described in the implementation section. And then there is a newly designed survey that would be part of this evaluation plan that would be for the HRSN beneficiaries, used to capture even more information on the receipt of services, the need for HRSN services, use of different emergency services related to their HRSN needs, as well as thinking about their healthcare access and especially their self-reported health and well-being. I already mentioned the use of the flex services data to understand the landscape of health-related social needs services that have been provided before and after. And I should also mention the use of electronic health records, potentially for some very specific disease management, chronic disease management measures when appropriate. So that is the overview. So we can go to the next slide for discussion and feedback. And then the last slides just kind of walk through those next steps. But that was a lot of information and trying to balance that high level overview with some details, but happy to take any questions, feedback. That's what we're here for.
Okay, I'd like to thank you, Carrie. Really, really wonderful overview. You guys have been working so hard on this. It's really coming together. It's been a pleasure to watch it mature. It's really been great to see that. Are there any questions from, I do see Caroline has a question. Her hand is raised.
Good morning. I just want to make sure I'm understanding. So for some of the, I guess I might call them softer measures that are harder to track through EMR data, like chronic disease management. So the climate data, the nutrition data, collecting those outcomes, am I understanding correctly, will be primarily through surveys? Is that what you said?
Yes, yes.
Okay. And then in terms of the housing outcome kind of data, is that also survey, or are you pulling from other data sources that are tracked?
Right now, we've really limited it to the self-report. And as we continue to understand more about the the population that will qualify for the housing benefit. There could be the potential to look at some other types of data. We've talked a little bit about HMIS data, but we've been trying to really make sure that there's enough of a connection to those outcomes to make sure that it's worth that time to get that data and take a look at it. So
Thank you. And what target size response are you hoping for from surveys? And surveys, as I think we all know, are notoriously hard to get answers.
absolutely. And our goal would be to have multiple different outreach strategies to be able to gather that information. Our surveys in a population like this, where we also provide incentives, we pay people, of course, to participate in the survey and respond, are between 30–40%. So, yeah, we all would love to see even more, but that is typically what we're able to capture.
I mean, 30 to 40% of this volume seems like a reasonable selection. Seems like you're getting that would be a decent sample size. So, okay, thank you. Appreciate that.
Heather, yeah, well, thank you. I had kind of maybe on a somewhat similar vein to Caroline. I guess one, I'm excited that you're thinking about the comparison group of current CCO flex service recipients. I know that that's been a topic here over my tenure, last couple of years here on the advisory committee, about really trying to get a better understanding about how those services are being accessed and provided by the various different CCO plans. So hopefully this will give us an opportunity to get more solid understanding of what's actually happening in the field currently, and the opportunity to do more with the new waiver. So congratulations and thank you for choosing that. I'll give you and I'm looking forward to seeing more. I think it'll be an interesting process to try and collect that data. I guess that's a comment, but I would agree with that, and that you're also monitoring the two ways, because I think that is another thing that has come up with the advisory committee members here, as we've thought about supporting making sure that we're really leveraging this opportunity to make a radical change in health disparity and improve outcomes for communities. We're hoping, I know we were all hoping, that this will really help move the dial. So I think that's a great place to take a peek. So I'm glad you guys pulled that out as a population comparison. And on that note, as you probably are going to guess, I do hope that we get to ratifying population audiences that we're really wanting to focus on, because I love the plan that you've prescribed here and the way that you're looking at implementation. But I really would love, as an advisory committee member, to really make sure that when we're picking eligible populations, that there's enough consistency across the three benefits, and that we're really honing to health equity and reduction of disparity when we make those population choices. I know those are hard choices to make, and I know that when you make eligibility choices, someone gets left out, and I understand that, and I know it's hard, but we're getting close to our vision of 2030, and as an advisory member, I just really strongly advocate that the guidance that comes out to adhere to the eligibility, the guidance on how those services are coordinated, be very targeted to helping us achieve our health disparity outcomes. And I see it woven in here, but and I know that you're working with many stakeholders to develop this, but I just really want to strongly advocate that we stay extremely focused on the topic, and that we make choices that keep us tightly adhered to the progress we want to see. Does that make sense what I'm saying? I know I'm kind of going on here, but and you have the right mechanisms in here, I think, to measure that. I really appreciate that, but I still see that it doesn't feel quite as tight on the eligibility as where I would hope it would be personally. And my hopes and reality are often not aligned with the outside world. I totally get that. But thank you for listening to me. I appreciate it.
No, thank you for speaking to that. And well, I can't at the moment be able to describe all of the eligibility. I think one thing that is really interesting to the first point you brought up around the flex services is that their criteria is going to be different. And so it's interesting to be able to compare the populations receiving services through the HRSN benefit with the specific criteria that they have versus the population receiving those services through the flex services from CCOs. So I think this gives another place to kind of continue to even explore that eligibility criteria and the impacts of that eligibility criteria. And Lisa, I think, just posted a link to some of the additional slides that we tried to get in here, but we had a couple of slides specifically related to health equity and considering about equity considerations for the HRSN benefits as it relates to the evaluation. And that is one of the things that was listed on that slide as well. So.
How people, who is receiving a service, and is it changing engagement and access for particular populations? I like those, as you can imagine. And so I see them open in here, and yeah, I really appreciate that, because that's the kind of data we don't currently have to move the needle and make sure the practices we're implementing will get us quickly to where we want to be. And so I'd love to, I think you're on the right track, and I just want to see more. So thank you.
Yeah, and sorry, I'll keep going too for a second. We have a lot of questions on the equity considerations section of the full slide deck that you just got linked, asking about sort of screening practices and how that's going to happen across different providers as well, which is another place where we could potentially see this eligibility criteria play out in different ways too. So we'll be really interested to hopefully be able to explore that. And we're trying to understand what data will and will not be available to answer those types of questions. But it's great to hear you reinforce that as a priority.
Is it? It is 11:17.
Could we have 2 minutes to tell you about some next steps? Yeah.
Sure.
Great. So excitingly, we have now completed at least a first working draft of evaluation designs for all the 4 waiver components you see listed on this slide. So not only health-related social needs, but the young adults with special healthcare needs, the continuous eligibility and temporary expansion, and then also a shorter one related to cost evaluation, which is also another area of the waiver that CMS wants to look at. So we have great big long documents that you can all dive into and provide feedback on, and we really welcome that. We are going to start Monday or Tuesday of next week. We're going to send around links to the whole shebang of each of these things, that you're super welcome to review those. We've also put together something that looks a little bit like this slide deck you just saw as a summary version of what's in the plan for each of those 4 topic areas. So for people for whom this is not, the first thing you think about when you wake up in the morning, that shorter slide deck might be a good way to get a sense of what's in the plan and provide feedback. Those shorter slide decks are going to be available in both English and Spanish. And then feedback can be provided. There'll be a link to a form that you can use, or there's an email address that we'll show you. It's on the next slides here that this group has seen before. That's also a way to provide feedback, just an email. And we are hoping to get reaction from folks, feedback sort of in the period of the beginning of next week through March 25th, so that then we have time to incorporate that feedback and get OHA an updated set of designs that they can send in to the federal government at the end of April. So we'd really welcome it. Talking to the MAC at each step so far has been super useful, and I hope you all see in the each of the designs where some of your feedback has cropped up. Like for instance, I remember someone saying in an early meeting related to health-related social needs benefits, don't forget to ask what happens when people exhaust the available benefit. Like what does that mean for the person? What does it mean for the providers who are trying to help them? You'll see that in there as a question. So I'm hopeful that you'll see your past input and have some other great input to give us on these designs, and look out for an email with a whole bunch of links to all these versions that you can review next week. If you want to go to the next slide, I think it just says it shows a timeline. Is that right? Yeah, and apologies for something happened on the formatting, and you have seen this before, but here we are at the just end of February, beginning of March, sharing draft plans for feedback. We will get the revised versions to CMS at the end of April, or OHA will do that. And then we'll really transition into a bit of a, while we're waiting for CMS feedback, some discussions about what's a good structure for ongoing involvement of interested parties in the waiver. So that's a potential future topic for discussion if you all are willing to keep having us back periodically. I think that's it for us. The last slide is probably more just contact information.
Hey, thanks for that. I just wanted to, as staff, let you know that we will follow up with MAC members by sharing out what we received from CORE when they send us the draft information, and we'll make that available on our website as well.
And Lisa and Carrie, again, I do see our committee members' comments reflected in your work, and just really appreciate everything you've done on this. And it's just, as I mentioned, I personally, as the chair, I just feel it's really coming together with great skill and attention. So thank you for that. Really appreciate it. And we'll look forward to giving you more feedback. So is there any further questions from any committee members? Okay. With that, we will say thank you to our guests, and we will move on to our next thank you update from our Advancing Consumer Experience Subcommittee, the ACE Committee. Now I'm going to go ahead and turn it over to Lisa Pearson, our advisory committee member, who is the chair of Advancing Consumer Experience Subcommittee, to bring us up to speed on the subcommittee's recent work. Lisa, are you ready?
Yes, I am. Thank you. Thank you very much. So we had a pretty full committee meeting this month. We had a lot of topics to cover. We usually start out with our consumer issues roundtable, where everybody can bring consumer issues to the table for themselves and for the community at large. One of the ones that came up right away was frustration from one of our members around navigating the Medicaid eligibility process for people who already have Medicare and are dual eligible, or for other older individuals, because there seems to be a lack of consistency among answers that they get from customer service at Oregon Health Authority. Ellen Penny, who's our state ombuds, shared that the best thing to do is to call the APD resource connection to get connected to the local aging and people with disabilities office, who can answer questions like, how can I stay eligible for Medicaid once I've gone on Medicare? There was additional discussion around some of the one eligibility system changes. One of our committee members, our consumer members, is also on an advisory committee for the one system. So we do have some voice on there, and we had some discussion around the changing eligibility requirements and the updates to the one system. Ellen also had a couple of issues around dental and vision access for OHP members, and told us that OHA is starting the rulemaking process in these areas, and will be engaging communities and have listening sessions to hear concerns before a rule advisory committee takes place to update those rules. I brought up an issue with NEMT. Our our particular district only has one agency that provides NEMT coverage for our area, our 3-county area. And it's not always working well. People have been left without rides when they were scheduled, and people have not been picked up when they were supposed to be, or taken to appointments when they were supposed to be. So my question was, who at OHA provides oversight for these requirements for CCOs? Who looks at CCOs and decides whether they're adequately providing NEMT? Ellen stated that the OHA quality assurance team requires that a CCO show a trend in complaints for there to be action taken on this. So it was recommended that we share this information with David Embody and CCO Services Manager Awab Al-Rawi, and also get our consumers who are complaining about this to actually file grievances with the CCOs, because a lot of times they talk to people about it, but they don't go through the formal complaint process. And so there is never a trend shown because there aren't complaints. So it's something we need to work on. And Carissa, another of our members, shared that there is an active NEMT technical advisory group happening right now. So we're hopeful that some good changes come out of that. I don't know that we have anybody on that committee. I'm not sure if Carissa's on there, but we're going to check at our next meeting and see how much representation consumers actually have on that advisory group. Sarah Weatherson, who's our staff person for the subcommittee, stated that the SCAN group and Care Oregon have ended their plans for a merger. That's something that the MAC was involved in writing a letter of recommendation, but it seems that it was fairly, that the public comment and input from this group and others was a big factor maybe in that happening. So it's good to see that, the voices of the community are being taken into account in those processes. We also are trying to finalize some new ACE committee recruitment materials. The ones that we have now aren't really useful, and we need more members, especially if we're going to become the consumer committee under the new CMS rules, where we would have to have 4 of our subcommittee members on this committee. We're going to need more membership, and so we've been talking about recruitment materials and a new application. We all provided some input on a first draft, and then that's gone back out. And there's a second draft that we will get later this afternoon that we will be talking about again at next month's meeting. We hope to have those finalized pretty soon, because we do have some people interested, and we've kind of had new members on hold while we're going through this document update process. And if anybody wants to give feedback on those or take a look at those, you can get in touch with Tom Cogswell to take a look at those. We're going to do final consideration of those at our March 19th meeting. We also had a brief discussion around identifying new subcommittee times and dates that are more convenient for consumers, because part of the problem is that we have to hold them during the workday, the OHA workday, for staff support. And for a lot of consumers, especially those that work, that's not always convenient. We are going to have a new subcommittee group that is going to work on new times and dates. We have been kind of putting it out in a doodle poll right now to get people to give input on the current members' available times. But we were going to put on hold changing our times and dates until we get more members recruited, which is likely going to start in about a month. So we want to wait for the newly recruited members to have a voice in setting those new times and dates going forward. So that's also on the agenda for probably 2 months from now, when the new members from the recruitment materials that will be this month's discussion come into play. So that's about it. That we did all of that in an hour and a half. So we are being productive. Does anybody have any questions? All right, well, I don't see any questions. You're always welcome to contact me or Sarah or Tom if you want any further updates or give input on any of this. So yeah, that's about it for us for this month. Thank you for your time.
So much. And I was gonna say, maybe we can vote for committee members, Lisa as the chairs of the ACE, and myself and the co-chair for the MAC. We meet regularly with staff, just so you know, and so we're really trying to coordinate and ensure that we have good cross-pollination across all the work products of our committees, and that we are working together on a cohesive and consistent process. Is that right, Lisa? Is that what we're trying to do?
Yeah. Yeah, so we have a co-chairs meeting after the ACE meeting. So we discuss things that we need to coordinate between MAC and ACE at those meetings, and those happen every month as well. So
yeah, and staff is wonderful in supporting us. Lisa, I would like to say, for the benefit of the rest of the committee members, I'd like to highlight a couple things that it sounds like you guys discussed this last meeting that have been kind of ongoing, larger MAC committee topics, as I know we have lots of MAC members who are new-ish, and whatever the time frame of your that, and just to keep everybody abreast. One is really appreciate your work on just continuing the conversation. I think this came up, correct me if I'm wrong, when the ombudsmans have presented, that it seems like for us to continue to kind of poke away at finding or encouraging or advocating for supports for consumers, so that they have support in better understanding, evaluating, or shopping, or just support for understanding what's available to them within the health plan, that can be very confusing for folks. And maybe that's an area to continue to kind of poke around at and see if there's good recommendations that we as a committee could have, or request that be researched and brought to us to kind of tackle. And I think the other one that continually kind of comes up, and I know it comes up particularly with the EMT, the transportation services, is trying to figure out how to create a process or make recommendations of creating a process around how do we centralize and make it easy for consumers, or and even providers. I will say that as a provider, representing providers myself, to report things that people just don't tend to report but are very problematic, like these transportation services. And that if we're really thinking about being consumer focused, that we make operations and procedures that meet their needs so that we can meet their needs, right? Like, you could, if we have a grievance procedure but it's so onerous that no one applies to it, how will we ever make continuous improvement, I guess? So I appreciate you guys talking about that.
Yeah, I also think that a lot of consumers don't understand that it's the CCO providing those services, because, for our area, the the Senior Disability Services Division actually is the provider of those services, and or at least our Council of Government, that their bigger umbrella is the provider of those services. So people don't really know that it's actually coming from the CCO, so they don't know where to complain. So that might be something that OHA could do a better job of, is, letting consumers know that, hey, these transportation services are part of your OHP and they are handled through your CCO. And if you have problems, go to your CCO. We had issues with people not being, they had rides scheduled on holidays and they weren't picked up. And there's nobody at the agency at Council of Government to answer phones during that day. So the people that got stuck had no way of contacting anyone. So those sorts of things, they need to know where to go. And they kind of anecdotally talk to people like me, and some of the other committee members that they know are somewhat connected about these things, but very, very few of them that I talk to, go through any sort of formal complaint process, and they don't understand how to do it. So that is somewhere OHA could help out. Yeah,
Well,
one
thank
other,
Lisa,
quick.
Oh, sorry. We're hitting the public testimony, the bell, and can you hold that thought? Is it okay if we hold thought?
Yeah, it's fine. We have one question. Peter has his hand up.
Yeah, I was going to ask that since we're a little overdue on public testimony, and you know how we like to try to be as timely as we can because people sometimes just pop in to do public testimony quickly. We try to keep that window open. Can everyone write down their thoughts, write down their comments? I hate to interrupt a good discussion flow because this is a good one. But if we can just interrupt that briefly so we can do our public testimony, and then we have time for further discussion, we can just launch right off back into this discussion in a few minutes.
Sounds great.
Oh, thank you, Lisa. I appreciate that. Apologies for having to be a timekeeper there for a minute. So thank you. As you heard, it is we're a little overdue. So thank you to any individuals who are waiting to do public testimony. We appreciate your patience with our meaty discussions here at the MAC. It is now time for public testimony. The Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct any inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual, and it is not a representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or the Oregon Department of Human Services. Each presenter is given 2 minutes to share. In the event that that does not feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we will start a 2-minute timer for each commenter. We will kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public commenter. In addition, please know that we will share any testimony regarding the 1115 waiver with the Centers for Medicare and Medicaid Services, the federal bodies, in OHA's quarterly report to that federal agency. Okay, so with that, do we have public comment? We have Tom. Tom, are you ready?
I'm ready. Thank you very much. And thank you everybody for this work you're doing. My name is Tom Sinsick. I'm a retired family nurse practitioner. My work in Oregon has been in primary care, corrections health, and largely in school-based health clinics. So I was glad to hear about the legislation advancing more school care in the schools. I love the continued mantra of complexity. How many times was it said today? Over and over again. And the idea of unwinding the tangled mess. You know how bad it is to unwind a tangled mess. This just calls for what we need to do is start fresh eventually while you're doing this work. And we look forward to doing that. I do have some things in particular. I want to share a couple of quick stories. I'm hoping they will be available for people to tell their own stories themselves that I've heard as people reach out to me as an advocate, spending my time volunteering to do this work. One was somebody got an increase in pay, $200. I'm not sure it was a week or a month, but that cut them into the exchange thing. They got kicked off their Oregon health plan and their new exchange dollars were $300. So they lost income as a result of a raise in work and losing and having to go to the exchange. Another one, and this I think looking forward to the future is, I love the Oregon health plan, but somebody said they had to stop at 5 places before somebody would take their Oregon health plan for their kids to be serviced. I'm hoping that that testimony will come soon. So I was excited also to hear about the environment, housing, and nutrition thing. OPHA is starting a food and nutrition section at their OPHA. I'm hoping to have a conversation further with that. We know there's a crisis in food and nutrition. Let's see, was there anything else in my little note? Oh yeah, but here's the recommendation. Hope you can fix this soon. Stop using the word consumer. These are not people using up stuff. I think it's a derogatory term in terms of what people's needs are. To call them consumers over and over again is problematic. So please change the language. Thank you very much.
Hello, I'm not sure if I'm having trouble hearing you all. Is now a good time for me to go?
Carissa, I'm not hearing anything either. This is Lisa. I'm not hearing speaking.
Okay, I'll just start.
Carissa, I'm so sorry.
Yeah.
I'm sitting here talking at you with the mute on and asking you if your mute's on, and it was me.
Okay,
So,
no
yes,
problem.
you may please start. Thank you.
Yeah, so I'm Carissa Bishop. I'm a OHP member. I'm on the ACE committee. And I did want to just reiterate, which I appreciate Sarah stating that she'll share my question that I have for the evaluation in regard to the HRSN benefits evaluation. But other than that, which I just would like to make sure that there's some form of tracking of people who are seeking these resources who do not qualify in the specific populations that are covered by HRSN and or the additional criteria that's required to receive them. That way we can get a bigger picture of who really needs them, who are OHP members beyond that, those specific groups. And then in regard to the ACE, advancing consumer experience, it's called the subcommittee, I suppose. I'm a little bit confused about this and would like to bring attention to this based on the CMS press release and the actual proposed rule in the Federal Register. It's my understanding that states will be required to establish the beneficiary advisory groups or BAGs that are standalone group that meet separately from the MAC, which that seems to be the case. One of the things I'm wanting to bring more attention to, though, is that the goal and the point of this proposed rule is to have this group made up of Medicaid beneficiaries, their family members and or caregivers, not advocates, not interested parties that are, working at OHA. I think it needs to be a consumer-led group, and it needs to be 25% of the MAC membership. I don't know if that equals 4 members or it could be more, where the beneficiaries serve on the MAC who are on the beneficiary advisory group. And therefore, I believe it should be called a committee. It's not a subcommittee of the MAC. It should be equal to the MAC. In terms of hierarchical structure, I don't believe that it's supposed to be below the MAC. It is equal party or partner. And hopefully I got my point across there. Thank you.
Appreciate. All right, do we have any further hands raised for public comment? Anyone asking for public comment in the chat? To the staff, was there any public comment submitted that needs to be read?
Thanks. We do have public comment that the commenter asked that we read into the record. So I will read that now. This is public comment from Bruce Thompson, MD, regarding Care Oregon scan merger. So I'm reading his public comment. I commend the MAC for your thoughtful consideration of the Care Oregon scan proposal. Your decision to oppose that transaction was most helpful in supporting a denial by HCMO, which is the Healthcare Market Oversight part of OHA. I also commend HCMO leadership and staff for their very thoughtful and comprehensive evaluation of the Care Oregon scan proposal. Medicaid patients in Care Oregon are much better served locally, and public dollars are more effectively spent locally. Promises of a better system and access for patients from an out-of-state entity are part of the smoke and mirrors that private equity and for-profit business models use to disguise their healthcare ruse as they strive to achieve their goal of maximizing revenue. With consideration for OHP patients in Lane County, I ask that the MAC OHA consider evaluating how OHP patients are doing in Lane County. The Optum, and you'll forgive me, I don't know what that acronym is, Eugene OMG, also don't know that acronym. Transaction in 2022 is now nearly 2 years old and occurred prior to HCMO being stood up as pressures from out-of-state for-profit entities are increasing in all areas of healthcare. It would be of value to confirm that OHP patients are not being negatively impacted by the Optum acquisition of Eugene OMG. There is much public information that would be available to do such an assessment. For instance, OHA could look at the BME, and I'm not sure what that means in this context, to determine how many OMG medical providers changed location after Optum took over. OHA could look at how many OHP patients visits are currently being seen by Optum OMG and how many were seen prior to Optum taking over in 2022. OHA could do a community review of OHP and other patient experiences. Specifically, since Optum took over, such an evaluation would serve as a step towards healing, particularly for Lane County Oregon Health Plan patients who may have been negatively impacted in their health care since 2022.
Thank you, Sarah, for reading Dr. Bruce Thompson's public testimony. And is there any further public testimony? Please raise your hand or note that you're ready in the chat so we can identify you and call you. Okay. Without seeing any further public testimony, we will go ahead and close testimony and thank everyone for their testimony today. And then we will enter back into our MAC discussion. And I believe we left off with Lisa wanting to bring up one more topic and a raised hand from Peter is where we left off.
So let's take Peter's question first so we don't run out of time. So, and then I can have a short discussion about the other item.
Thank you, Lisa. Peter?
Is Peter still here? Sounds like unfortunately we might have lost Peter in the interim, but I don't see him on the currently logged in list. So Peter, feel free to chime in if if you're still here, but I think you may be gone. The other item that came up at the ACE meeting is the question of whether ACE committee members who are not members of MAC are entitled to the compensation under the state legislation that provided consumers compensation for being on committees. Sarah's working on that and is going to bring back a answer at our next meeting, hopefully. But that is something that I think MAC should be aware of, is that we are unclear as to whether members of ACE are categorized as board members for being on ACE, since it is currently a subcommittee. That's probably going to change when we become a BAG, beneficiary advisory group, because we will be a standalone, but right now it's completely up in the air. So we are working on clarifying that, but I just thought you should be aware of that.
Just a couple of points of clarification. I'm sorry. Couple points of clarification. I have finalized that, and we, members of the subcommittee who are not also MAC members do qualify for committee compensation under the rule. And I believe I sent an email out to the group, but if you don't find that in your email, let me know. And then the other point of clarification around the subcommittee status is that the subcommittee has been a subcommittee of the MAC for several years now. There is this other proposed rule that CMS has not yet finalized, and until we have finalization of that rule, we have made a decision not to implement the subcommittee to not make those changes. That was a change. That was the charter that the current subcommittee has, was reviewed late last year to bring things in line. And the committee decided at that time not to change its charter to align with the proposed rules, because we wanted to see what came out of in the final rule before making that change. I have heard more recently that we expect by the end of April to see that final rule. So that is the update that I have on the status of that committee and how that committee structure may change. I will also add that one of the decisions we made in our last meeting was to take another look at our charter and potentially change some of the things in the charter, knowing that we think some pieces are very clear, whether or not there's some pieces that we know that the committee members want to do, the MAC wants to do, OEJ wants to do, regardless of what comes out of the CMS final rule. So that is something that we've, the committee said in their last meeting they wanted to take up in their next meeting.
Thank you, Sarah, for that update. Appreciate that. We do have our time now for any follow-up comments or questions, discussion from Medicaid Advisory Committee members. So as you've been thinking about all the discussions and information that we've had today, if there's any thoughts about future agenda items or things that you would like more information on, or just something that you found inspiring and insightful or concerning, now is the time to bring it up. Though you're always welcome to reach out to Lisa, myself, or Sarah to get those things on the agenda at other times also. So, anyone from the committee members? Any committee members? Discussion?
This is Lisa again. If anybody has consumers that are contacting you or that you know of who would be interested in being on ACE, please refer them to me or Sarah or Tom. We are interested in having more people attend even before our charter is amended. So we can invite them to attend the meetings, and we would love to have more member voices. I'm changing my terminology. Member voices on the committee.
Thank you, Lisa. All right, seeing no hands raised or chat or other, we're a whole minute ahead of schedule. Maybe we shall, actually we have an item. Goodness me. I wanted to take a minute to invite one of our longtime amazing staff members to share with the committee members a few words today. I think many of you know Stacy DeLon Davis. She has been pivotal in helping us get some of our video and training requirements done. I will forever be grateful to her to helping us through that and making sure that we are all have our T's crossed and I's dotted. And so go ahead, Stacy. Thank you.
Oh, thank you, Heather. Hi, everyone. I just wanted to say that you probably haven't seen me around that much, especially the MAC members. My work has been transformed into other things, and which is totally fine. So that just means that I am transitioning off the MAC. And so that's probably why you've been seeing Jordan more and Tom more in your communications and in your interactions, because they are taking over some of the work I've been doing, along with Sarah, of course, because Sarah's the best. But I just wanted to do like the whole cheesy gratitude thing for all of you, because I feel very connected with a lot of you. I started at OHA 2 years ago today, and my first task was to recruit MAC members. That was literally like my priority and the first thing that was asked of me. I didn't know what that even meant at the time. I had recruited in other, in my other career in the past, but I've never recruited for a federally mandated committee. So it was a little different for me. And then to throw even more curveballs, I had to learn how to use Workday. So learning how to use Workday as a new employee myself, and then also helping some of you navigate what that looks like, was something that I will always remember. And honestly, it has helped me with knowing what I need to do and where I need to go and how to navigate Workday. But I just want to say that I am very proud of this committee and what it has transformed into. A lot of the times before, we heard a lot of comments around people coming to the MAC and just giving updates, and there was really like hardly any engagement, and I've seen that big shift over the past 2 years, and I'm really excited for y'all to be able to have a voice to share your concerns and provide feedback. And I also just want to say that, knowing that I helped with the recruitment of some of you, and seeing in your application that you were all very passionate about Medicaid, but not just passionate, you also have the desire to change what that looks like for our state, and then hold us accountable too. So I just want to say thank you, and thank you for the time and giving me the time in the space, and also thanks to Sarah and Tom and Jordan for taking you to different places. I know it'll be very great, and I'm excited to see what happens and what topics and focus areas you'll have from the retreat. And yeah, you know where to find me. Sarah and Tom, we're on the same team. I'm not too far away. They know how to get in touch. So I'm sure I've texted with some of y'all and emailed some of y'all before, so you know how to find me. So thank you.
Thank you, Stacy. It's been a pleasure to work with you, and really appreciate your support to all of us on the committee, and myself especially. So thank you very much. Thank you. Any other
Stacy, I'm just going to jump in. This is Caroline. You helped recruit me, and I have very much enjoyed working with you. And please stay in touch. And I would love to go do a fun run with you since you saw me running last summer. But thank you very much, and good luck in your new role.
One more topic really quickly. I scrolled back through the chat and found Peter's chat comment that he put in, and he said he wants to put out there that he can't find a web page for ACE on OHA's website, so that it might be hard for consumers who are looking for information about it to find it. So we might want to do a review of the website and figure out whether it's up there or not.
Thank you, Lisa. All right, we have 1 minute for plus deltas. Oh, darn. So Sarah, if you want to lead us real quickly through that. I know folks may have to jump off. Everyone's time is tight these days.
Yeah, so if there's a minute to let us know how we're doing, we always want to take that time in the spirit of continuous improvement. Anybody, is there anything that went well today that you'd like to bring up?
This is Lisa. I'm just going to say that the agenda and the time periods for the presentation seem to be appropriate. We've had some trouble with overstuffing the agendas in the past, but I think it worked out.
Great, thank you. Any other comments? Okay, anything that went poorly or you'd like to see change? Okay, hearing none, we'll let you all go. Thanks so much for being here today. And we will meet again in Portland on April 17th. So it's a little bit off from our regular schedule at 9 a.m. Looking forward to seeing you then. Take care.
Thanks, everyone.